Okay, so I'll record this again. I've been spending 2 days trying to figure out how to put my previous vital signs and stuff up on Canvas from last year, and it's just not working. Just not working. So vital signs is encompassing all of the things that you will be doing for your patient. We used to never think about taking temperature on a patient unless we thought they were tuberculosis or something. We never took temperatures. Now, guess what? That's part of our protocol, taking body temperature. So we are teaching you how to do things the old-fashioned way, as in blood pressure, the old-fashioned way with a cuff and a stethoscope, because automatic cuffs are wonderful and they have their place. They don't necessarily have their place in dentistry. Our books don't like automatic cuffs because it's very difficult to calibrate them. But I've been taking blood pressure since I graduated in 1981. When you graduate from school, you will be determining what is important for you. What can you give up? What can you keep? What, do you want to keep? That type of stuff. Well, blood pressure and pulse was one of those things that I've just always, since 1981, never not taken it. But I used a wrist cuff. I got my own wrist cuff and I calibrated it with an arm cuff, and I would only use the manual cuff if the wrist cuff was giving me something really wacky. The last office I was in, I was the only one aside from the doctor who knew how to use a traditional manual blood pressure cuff. So I would have the other hygienist come to me, Betsy, can you take a regular blood pressure on my patient? The wrist cuff is, and I'd have to excuse myself and go take a manual blood pressure. So once you learn this, you will always know it. It's not that we expect you to use a manual cuff all the time, but you'll never be stuck without not being able to take a blood pressure for a patient. All right, so your learning objectives, okay, and again, when you're going through, these are the objectives, all right? This is, so Kathy, these are the objectives that we're talking about, and they're in the beginning of each chapter, all right? These are more specific to the specific thing.
I noticed those, and I was wondering if those could be just used as a study guide.
Recognize normal vital signs. Well, guess what? There are a lot of questions that can come under that. Your patient's blood pressure is such and such and such and such. What does that mean?
Okay.
So we are going to be doing a lot of this, and we start our education with the very beginning of the process of care and go through. So we're doing medical history, you've done. Now we're talking about vital signs, blood pressure, pulse, respiration, the temperature of the patient. They will be giving you their temperature when they come back to you. Right now, we have what we call the clinic assistant. One of the students is assigned to be clinic assistant. They are taking the temperature of the patient, giving the patient a slip of paper that they're then giving their hygiene students. So we can mark it in the medical history that the patient answered no to all the COVID-19 questions and their temperature was such and such. So it's important that the patient know that we're taking vital signs for them, and we do this on everybody. We're not doing it on you because we think you look weird. We're doing it on everybody, and we're doing it on everybody each and every appointment, okay? Because there's so much related between what's going on in the mouth and what's going on in the body. We just let them know. This is what it is. If they refuse, then we're saying bye-bye. This is not the place for you. Okay. So we start out with body temperature. Some of us are naturally cold-blooded. Some of us are naturally hot-blooded. Our temperatures do fluctuate throughout the day and throughout the month as well, especially if you're a woman and your hormonal cycle. So there are indications for when we need to take a temperature. It's not one of our norms until COVID hit. But if a patient comes in and they have an oral infection, for example, we want to know, what is their temperature? Is it a systemic thing right now? Okay, because they are going to have lymphadenopathy. They've got lymph glands all over their body. Are they swollen? Are they tender? Do they have a fever? A lot of times the dentist will determine to prescribe antibiotics whether or not they have a fever. Okay, so offices do take temperatures. Other vital signs are important for pre-medication. For local anesthesia. Respiration is important also if you're going to be doing nitrous oxide. So we're going to be getting into more of that. You have a whole semester on local anesthesia and nitrous oxide, and that's what our second year students are going with now. They get to inject Mr. Plum tomorrow. When you're in radiology, you'll be seeing them with their plums and their needles and stuff. It's a lot of fun. And then they get to poke each other. So you all will be doing that just a year from now. So there's a lot of different ways to take temperatures. We're using a non-touch way now. This one is actually touching the forehead. This one goes in the ear. And this one goes under the tongue. And we're using an infrared light. This is the one I have. I've had it for years, but the digital part stopped working. So I had to go and get another thermometer. So I've got one now that doesn't touch your face. They also have one with a little roller ball, which I thought was so cool. You just take this little roller ball and roll it. Not touching is the safest way because there's no asepsis that you have to worry about. Pulse, very easy to do. If all of you know where your own pulse is, I charge you with finding where your brachial pulse is as where is your radial pulse. So you can help your partner. Some pulses are going to be very superficial and right underneath the skin, and you're going to feel the bump, 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 bump. Others, you got to fish and go and press harder and that type of stuff. Same way with the brachial pulse. You can't see me, but I'm taking my brachial pulse now, telling me where to put the stethoscope. And some of us will have stronger ones than others. So if you know where yours is on you, you can help direct whoever is working with you. All right, so we're taking the pulse. We're taking it for a full minute. Nursing schools, other places will say take it for 30 seconds and multiply it by 2, but you don't get a full breadth of any irregularities if you're doing that. So we are teaching best practice. Best practice is to take it for a full minute. So you've got your hands on that patient's wrist for a while, okay, at least a minute. And most of the time you've got it on there for 2 minutes because what we do is we'll take the pulse first and we'll keep our hand there to take the respirations because we don't want to tell the patient, now I'm going to be staring at your chest to watch how you breathe. Guess what? We're going to be changing how we breathe. So we don't want the patient to be aware of what we're doing. So find out where your radial pulse is and your brachial pulse. You don't want to take your pulse, obviously, with your thumb because your thumb has a pulse in it by itself. So you are cupping your fingers, all right, around the thumb side for your radial pulse. We had one student, this was years and years ago before we were even on this campus, who had to leave the program because she got squeamish trying to find the radial pulse and trying to find where in between those tendons and everything. She just couldn't handle it. And I said, well, you know, you're going to be doing this on all of your patients. She ran away, unfortunately. Okay. So be familiar with pulse. You're taking your pulse for how long?
1 minute.
1 minute.
1 minute, okay? None of this, you're taking it for 15 seconds and multiplying it by 4. So know what your normal range is, okay? And know what bradycardia is versus tachycardia, okay? What is a high pulse rate? What is a low pulse rate? What can that mean? Respiration. We're breathing in and we're breathing out. We are putting qualifiers on all of our vital signs. Are they full? Are they thready? Is the pulse thready? You can barely feel it. Or is it bounding? Ka-bump, ka-bump, ka-bump. You know, is it wheezy when they're breathing? Okay, is it a full breath or very shallow? That type of thing. We're putting qualifiers on our respiration and our pulse. And know also what the normal is, 12 to 20. If they're below 12, what's it called? If they're above 28, what's it called? What do you do if it's over 60? If they're breathing over 60 respirations per minute, you're calling for help, okay? So just as it's bradycardia and tachycardia, it's the same thing, but with the P-N-E-A after the end of it for the breathing, apnea. Increases in respiration, work, exercise, excitement, nervousness, strong emotions, pain. Think about who you're going to have in your chair. They're nervous, okay? Their pulse is probably going to be up. Decreased respiration can be caused by sleep, certain medications or drugs, pulmonary insufficiency. So look at the chapter, the tables in the chapter for emergency situations. So you're observing their respirations. You're making a count of the respirations immediately following the pulse, and you've still got your hands on them, so they don't know that the pulse has stopped and you're taking the respiration. Hopefully you're just asking the patient to close their eyes and relax for a minute or two, because if they're staring at you, they can tell that your eyes aren't on the clock anymore. And it's important also when you're doing this that you have something with a second hand or a timer available. Now we have computers. You can turn the timer on the computer or the clock on the computer. That's what a number of students do. We do not want you using your cell phone when you are in clinic. Okay, the cell phones have been known to be dirtier than a toilet seat, like a computer keyboard. We don't want you handling it. Some students will get, if they're in the middle, if their home is in the middle of a row and they don't have a clock accessible to them, they'll bring a little clock with them and have it on their counter, okay, that they can use, and it also helps help them keep track of time when they're working, so they don't have to swing out into the middle of the corridor area to see a clock. All right, so it could be that you need a watch with a minute hand on it as well. Okay, but you don't want to be using your phone. So you've got your hand over the radial pulse, and all you're doing is you're diverting attention, and then you're looking for the number of chest rises in a minute. Is it shallow, normal, or deep? What's the rhythm? You're looking at the depth and the rhythm. Is it regular or irregular? Okay, is it spaced evenly? You're looking at the quality, and you're describing strong, easy, weak, labored, or noisy. So what I recommend students do right about now is to start what we call a clinic notebook. And this clinic notebook will be your cheat sheets. In Clinic Help, under Clinic Help in Canvas, you have to scroll all the way down past all the weeks and everything, week 16. Then you'll find some clinic stuff. There's your clinic mentors there, your advising form is there when you meet your clinic mentor, but then there's clinic forms, your skill evaluations are there, and there's clinic help sheets. How do you approach a medical history? They have patient operator positioning, a cheat sheet there. You can print out those things and put them in a clinic notebook so you can have them to reference in clinic. So you don't have to memorize the depth, rhythm, quality, that type of stuff. You don't have to memorize all the words. You can have a cheat sheet for respiration with strong, easy, weak, labored. I mean, just with those words. And then you can just pick the words and write them in. So we want you to have what you need accessible to you. Does that make sense? It's okay to have sheet notes, all right? So you can start your clinic notebook now if you find, especially when we are starting with oral inspection, EO, IO, and the terminology, okay, pedunculated, nodule, indurated, those type of words. It's a different language. And if you've got those words already down with the definition next to them, you can use your clinical terminology properly. Instead of saying a small red dot, we want you to say petechiae. Okay, blood pressure. Boy, did I have to scramble trying to find blood pressure cuffs yesterday. Physical therapy, dental assisting, us. You will have your own blood pressure cuff. You will have your own stethoscope if we ever get our kits. So you need to know the components of a blood pressure because you will be taking this on each and every patient every time they're in. Now with us, once we learn blood pressure, we're going on to the next thing and vital signs. So you're not going to be taking blood pressure each and every appointment. So when you do get your kits, have the, take your blood pressure cuff home. Take it on everybody, anybody. Okay. Can we use the cheat sheets during skill evaluations? No, but you can just use them to learn better and have them as a reference for when you're writing your notes. Because the more you look at them, the more you're going to learn them, especially with the terminology. So you need to know the components of the blood pressure. And blood pressure really is the force that's exerted by the blood on the blood vessel walls. So when the left ventricle of the heart contracts, the blood's forced into the aorta and travels through the large arteries into smaller arteries, arterioles, and then the capillaries. And the vessels of the heart, okay, there's a something in chapter 69, I think, that shows all of that, but we don't need to know that. But the pulsations extend from the heart through the arteries and then disappear in the arterioles. So during the course of a cardiac cycle, the blood pressure is really changing constantly. So we've got a systolic pressure and a diastolic pressure. The systolic pressure is the peak or the highest pressure, and it's caused by ventricular contraction. So the normal systolic pressure on an adult is less than 120 millimeters of mercury. 120 is the start of high blood pressure. It used to be 120/80 was our textbook normal. Now it's below that. Same thing with your diastolic. The diastolic pressure is the lowest pressure, and it's the effect of ventricular relaxation. So the normal diastolic pressure is less than 80. Typically, there's about 40 millimeters of mercury between the top number and the bottom number. 120/80 is 40. Okay, so there's usually about 40 in between the two. And then there's pulse pressure, and the pulse pressure is the difference between the systolic and diastolic pressures. All right, that's your 40. What are some of the factors that influence blood pressure? Oh, excuse me?
I have a question. So you said 100 for systolic is under 120 and for diastolic is under 80, right?
Mhm.
So that would be, if it's in that limit of 120 and 80, is that a normal, or is that if it's 120?
120 over 80, what you're going to do is look this up in your procedure manual to see what is it considered. Is it considered pre-hypertension? Is it considered elevated hypertension? Because 2 years ago, they changed it all. It used to be 120 over 80, now it's not.
Okay.
And again, there's a chart on this in the clinic help section. So I do want you to become familiar with that clinic help, because I've spent years trying to put things in there to help. Literally, help.
Mrs. D, I had a comment about that real quick. I don't know if you were aware in the blood pressure video that we watched, it said, hang on, this thing is dinging, I'm sorry. It said that normal for, I think they said greater than 60 years old was 150 over, I can't remember what the diastolic was. I have it in the notebook that I left in clinic yesterday.
Yeah, wrong.
That was so
Your
odd.
red notebook.
My red notebook, yes. I had it written there because when I watched the video over the weekend, I saw that and I thought, what? I've never heard of that before. So I just thought I'd point that out to you.
Ignore it.
Yeah, I told Mrs. Kane and in clinic, and she said, no, that's not
Yeah.
it. I thought things had just changed since I last knew, you know? So, okay, just wanted, she said to let you know about that. So
I love my faculty. You have such great first-year faculty. Oh, I love it.
They
I
really
love
are.
it. And please know that we really are here for you. Some schools, not so much. It's like, ooh, let's see who I can make cry today. It's just horrible. So know what the different parts of the equipment are. You need to know what kind of sphygmomanometer you have, what type of equipment. Is it an Android or an analog? Is it electronic, right? You are using the non-electronic ones. Okay, you're using a portable glass enclosed gauge with the needle. You need to know how to read that. You need to know how to listen for it, all right? Some people cheat and say, oh, I never hear it and I just wait for the bobbing of the needle. That's not your blood pressure, okay? You need to also choose the correct cuff size, all right? So that is showing you on figure 11.4 for the cuff size there. The cuff should be long enough to encircle 80% of the arm and wide enough to encircle 40% of the arm at its midpoint. The longer and wider the cuff, all right, you need to use for the larger people. We have pedo cuffs in the storeroom, and we have large cuffs in the storeroom. I have a large flabby arm, and I always request, if I can get a thigh cuff, I want a thigh cuff, because the larger cuff is going to give a more accurate reading, and it generally gives a lower reading than something that is squeezing so tight. So you want to make sure that the cuff fits. You are getting the standard adult cuff, but if you've got somebody that's 100 pounds, you might need to get the pedo cuff. There are wrist and finger devices, and they're considered less accurate and really aren't considered for professional use. But I have used a wrist cuff since 1981, and again, it's better than nothing. It's better than nothing. And when you're introducing blood pressures to your office, if they're not used to taking them, sometimes having something like that, because the doctor's going, that's going to take 3 minutes. And in 3 minutes, you could be doing this, this, and this. It's just easy. You don't have to worry what the patient's wearing or anything. Your stethoscope, okay, has a diaphragm or a cupped end piece. There's usually an on and an off with the stethoscope. So what you do is you kind of tap the diaphragm a little bit. If you're not hearing the tapping, then you need to twist the diaphragm to turn it on. So get to know what your particular stethoscope needs. And then there is a procedure for determining the patient. So you're going to tell the patient that you're taking a blood pressure. You're going to tell them that when you do this on everybody, you're going to be doing it on you each time you're here. It's part of the routine, all right? You're not, nobody's special. And I can't tell you, ladies and gentlemen, how many times over the years patients have called me and said thank you, because I was the only one that's ever taken their blood pressure aside from their physician, which they never go to. So you really are doing a service for the patient. And if they're not used to taking their blood pressure, or it's a little bit, guarded, then, I'm telling my patients, well, every time there's, if you're at Safeway or Giant or Target or Walmart or whatever, there's always these blood pressure things that you can stick your forearm in. We even have one outside of the bookstore that anybody can check their blood pressure at any time. That lets the patient know what their normal is, so that if something changes and it all of a sudden goes high, then they might be alerted, because this is called the silent killer. So you want to have the patient seated comfortably. You want to have the arms slightly flexed with the palm up, and the whole forearm is supported on a level surface of the heart. Okay, the whole forearm. So you don't want their arm just dangling in the air. You don't want to, as I've seen it, some people will take the patient's forearm and literally, as you're standing, will put it underneath their arm. And that is just highly inappropriate. You might be supporting the arm, but think about where that wrist is on the patient, and think about how that patient might interpret that type of touching, especially if they're from a different culture. It could be highly inappropriate. So you want their arms supported, and that's where we will have the patient lift up their right leg and put their forearm on their knee. Okay, that's just how we've come across doing it, and hopefully that's how you learned it yesterday as well. So you want the proper sized cuff. Either arm can be used unless indicated. So if I was a woman that had a mastectomy and my chair is on the patient's right side, so I tend to take blood pressures on the right side. But if I had my right breast and lymph nodes removed, I would have to take the blood pressure on the left side. Or if I'm a lefty, that is their normal, the lefty's normal, so they normally take the blood pressure on the left arm. So that is where that RAS and LAS comes in. Right arm sitting, left arm sitting. Okay, which side did you take it on? Because there's some slight fluctuations with that. Ideally, you want to take the blood pressure on a bare arm, okay, ideally. All right, so this is where the 40% and all this other stuff comes in. You want to see the crease of the elbow. You want to feel for the brachial pulse, because that tells you where to put the stethoscope, the diaphragm of the stethoscope. You're not just tucking it in under there and taking your best guess. All right, if you can feel the pulse and you put the diaphragm of the stethoscope over that pulse, you know you're going to get an accurate reading. Everybody takes blood pressures differently. And when I see about this time, the nursing students and the physical therapy students and everybody's taking blood pressure out in the halls, I, of course, have to sit down and ask them, okay, what department are you in? How do you determine how high to raise it? And some programs are saying we just do it to 160. We just pump it up to 160. Well, what happens if my blood pressure is 165? You need to then deflate it and pump it up again. Or what happens if my blood pressure is 110 and you're pumping it up to 160? The idea after you apply the cuff is to determine how high do you need to pump it. And that's when you locate the radial pulse, right? I felt for the brachial pulse. I put my stethoscope in there. I asked the patient to hold that there. So that's X marks the spot. They're holding it there. They're helping us, and that's fine. I'm feeling for the radial pulse. I'm starting to pump and my hand is on the radial pulse and I'm pumping, pumping, pumping. I no longer feel the radial pulse. That means I have cut off all the circulation in their arm. Cut it off. So that is the start of the blood pressure. So I say thank you to the patient. I then take my hand and I'm holding the stethoscope end, okay, the diaphragm of the stethoscope for the patient and making sure that I've got good contact. I'm inflating it about 10 to 20 millimeters of mercury higher than when I stopped feeling the radial pulse. So that's going to vary from patient to patient because we don't want to hurt the patient either. You take a blood pressure on a frail, skinny woman who's in a nursing home and you pump that thing up to 160 and you only needed to pump it up to 110, guess who's going to be bruised? I've seen some tremendous bruising in facilities. So we want to customize our blood pressure for the patient, okay? We're finding out where that diaphragm of the stethoscope needs to be. So again, I'm having the patient hold this while I'm feeling the radial pulse. Once I no longer feel the radial pulse, I'm then taking this from the patient and holding it so I can make sure that there's good contact. Usually 2 fingers on top, my thumbs underneath. Right? You want a straight arm so there's no air going through here. So this is where if the patient's knee is here, it's fine. You want to be able to see the end of the stethoscope. Make sure that you've got the earpieces in properly. It makes a huge difference on how that sound is being transmitted. Should be pointing in towards your ears. Okay, now, do you see what's wrong with this picture? He's holding the stethoscope nicely. He's got nice firm hold on that stethoscope. The arm is at a heart level, but where is the patient's arm? It's on the student's or the operator's knee. Too much touching, okay, too much touching. We want to give the patient their personal space as much as possible. All right, so you need to know what HTN, hypertension, is, all right, and what the parameters are. So you are going to be looking that up. There's a chart, not only in your procedure manual, but there's also a chart in the clinic help that's color coded. Hypertension, anything above 140/90. Above 140/90. Some patients have white coat syndrome. Just because they're in the dental office or they're having their blood pressure taken, they become anxious and they're going to have a high pulse rate as well as high blood pressure. I am one of those. So I always ask, take it again. It'll come down. I can get it to come down 10 to 15 millimeters of mercury just by taking it again. So I always have to have that second blood pressure taken because of my white coat syndrome. So on new patients, and new recares, the first time you see the patient, you're taking the blood pressure twice and you're averaging the 2. If it's within normal limits, every appointment after that, you only need to take it once. So for new patients or first time recares, you take the blood pressure twice and you average it. And the template will walk you through that as well. So what can cause hypertension? Cardiovascular diseases, strokes, kidney failure, okay? They can all lead to premature death. So it's important that we advise the patient that we're taking their blood pressure, what it means, and why. Have you ever had your blood pressure checked out? Well, this is a little on the high range. We consider you pre-hypertension. What I would recommend is that you just start checking your blood pressure to see what your normal is. And if it continues to be this high, maybe you need to be getting it checked out. Okay, so that's the language that we want to use for our patients. This also will determine whether or not we can give local anesthesia with epinephrine, without epinephrine, and that type of thing. It says recheck within a year. Guess what? We're going to recheck it every time, and we're going to tell the patient, you should know what your blood pressure normally is. Lifestyle modifications for all levels of blood pressure medication. Oh, my doctor wants me to reduce the salt intake, lose 30 pounds, and exercise. Well, I'm not doing either of them. So give me my HCTZ, my little water pill, give me my antihypertensive and my cholesterol medication because I'm not going to do it. Okay, where is your patient on that spectrum, and how are they doing with it? I started 6 weeks ago. I've lost 10 pounds. I've reduced the amount of salt. I'm really interested in seeing what my blood pressure is. Okay, is it working for them or not? And then give them words of encouragement. And again, we end everything we do with document, document, document. Vital signs are part of a comprehensive medical history. We take them on everybody, each and every time that they're here. So you see them in the morning at 8 o'clock or 9 o'clock, and you see them again at 1 o'clock, you're redoing it, okay? Doesn't take that long. Are there any questions?
Miss T?
Yeah.
Hello. So from the manual, the yellow book we got, it is said over 130 is hypertension stage 1.
Mm-hmm.
But from the book, it is said over 140 is stage 1. Which one is correct?
The book still has the old, the manual has the most current.
Okay, so we go by with the manual, the yellow book, right?
Yes.
Okay, thank you.
Yeah, go by the yellow book. By the time, this is a brand new edition, but by the time an edition comes out, the information's already 2 years old because it takes that long. Okay, I will be near my computer, so email me if you have any problems. And